I'm big on using a timer. I don't like guessing on anything that I do, whether that's topical anesthetic, whether it's waiting for the anesthesia to work. I pretty much have it down and, know the material that you're using. What's the set time? I place gauze over the crown, trying to keep it as dry as possible. Once the buzzer goes off on the timer, we go in, remove the excess cement, floss it, do what we have to.
Welcome to the Phil Klein Dental Podcast. Today we'll be taking a clinical journey through the delivery of a zirconia crown. We'll talk about the scan, marking our margins, working with the lab, choosing the right kind of zirconia, and discussing the tools and techniques for seating, adjusting, and polishing our zirconia crown. Our guest is Dr. Marty Jablow, a popular key opinion leader. He speaks a lot on dental technology. He has a tremendous amount of expertise in chairside dentistry. He's a sought-after lecturer and consultant to the dental manufacturer community, and we're very happy to have him on our show. Dr. Jablow, thanks for joining us.
Thanks, Phil. It's a pleasure to be back.
Yeah, absolutely. We appreciate all your contributions you've made to Viva Learning over the years, webinars, podcasts. You've been with us a long time, and really appreciate your input. You're one of those guys that are in the trenches when it comes to dentistry. You're doing the actual real stuff. For a doctor to be in the trenches and really know what it's like to deal with the challenges that the typical clinician has gives your insight so much more relevance and credibility that we really enjoy having you on the show. So before we get into the techniques and the tools for chairside adjustment of zirconia, which is going to be the bulk of what we're going to be talking about today, because zirconia is a very strong, hard material, and we do have to think about adjusting it, contouring it, polishing it. You're going to help us with some of those techniques as far as your experience. But before we go into that, tell us your journey in your transition into zirconia, and tell us what materials you were using before and how has zirconia treated you as far as success and failures.
So let's see. The journey into zirconia was quite a while ago at this point, and it came from mostly a PFM world, and then we were doing some, lithium disilicate, EMAX. And then, we had to bond it, and there was all the steps involved. Whereas zirconia, when I transitioned into zirconia, I found that we were getting better results. And the results weren't that we were getting bad with EMAX. The reason was that it was more about how it was a lot similar to PFM. We would take it, we'd cement it. It was all done the same way. I wasn't bonding them in. And that was kind of how I transitioned. And I found that even though I was taking conventional impressions at that time with PVS, I was getting better fit and finish. I don't know if I realized at the time that many of the labs were scanning the impressions at that point and then milling it, because this was quite a while ago. But I think that's what was happening, and I was getting better fit and finish. For most cases, single units, small 3-unit bridges, and then obviously when we transitioned to large span implant stuff that was all zirconia, I said, this stuff is pretty darn strong, and I can kind of transition out of PFM. That doesn't mean I don't occasionally do a PFM. There are indications for that. But I would say probably 95% of my work right now is in zirconia restorations, usually either completely monolithic or, using some kind of shaded, what they call Bruxer anterior, katana, that kind of stuff that gives me, a little bit better aesthetics to the zirconia itself, rather than just trying to rely on stain.
So with these additional options that we have for our indirect restorations as far as tooth-colored material, we really have to have a good relationship with the lab. We have to know the lab's capabilities. And when communicating with the lab, we certainly want to, in the case of zirconia, make sure they understand our aesthetic requirements for that case. Higher yttrium, you're going to get better translucency. And of course, if we're looking for strength, we're looking closer to a 3Y. So this communication with the lab is so important when we're trying to balance aesthetics and strength.
Yes, especially when you're doing, the entire anterior. It's hard to match an EMAX crown to a zirconia crown to a PFM. I mean, the materials are so diverse that it's hard to match them very well. But if we're doing, the front 8 on the maxillary arch, I can do that in a very nice zirconia and get a very nice result that the patients are happy with, and reduce my chair time because it's easier to cement it than go through a full, get them bonded and do all of that.
So regarding cementation of zirconia, Dr. Jablow, we talked offline, and you're a proponent of cleaning the inside of the crown, making sure the tooth is clean, keeping the tooth slightly moist, and then you go in with your luting cement, and that's it. You're not a real proponent of meticulous bonding, air abrasion, MDP primer. In most cases, you're relying on the prep itself, the retention properties of the prep itself, and the cohesive properties of the cement, and that's it when it comes to putting in your zirconia crowns.
Zirconia bond strengths aren't great usually to start with, not like when we get into Emax. So what we're really looking at is back to the bread and butter of what I call preparations, good resistance and retention form. If we've got great resistance and retention form, as they used to tell us in dental school, it doesn't matter what you put it in with. So, I always come back to the preparations. Preparations still need to have certain basics that will apply. I mean, doing those flat top posterior preps and trying to bond zirconia on them, your mileage may vary, as they would say, versus, okay, an Emax crown will do that quite nicely. So again, like everything else, it's case selection and, what tooth structure do you have left? What the occlusion looks like? How much room do you have? I mean, all those factors come into play in selecting the proper material for the proper situation. So sometimes it may be Emax, sometimes it could be a PFM, like I said, and then most of the time for me, it's some version of zirconia.
Now, with the additional strength of zirconia compared to what we have been using in the past, are you finding that you're doing less tooth reduction because your restorations could come back thinner?
Yes, absolutely. When you're prepping the teeth, this comes back to all the selections you do. What burr do you use? It's not one size fits all. If you know that you need 1 millimeter of reduction and you want to put a chamfer or a shoulder, depending on your preferences, select a burr that's 1 millimeter in diameter at that point, so that when you bury that in as a depth cut, you can just pass it around. I use electric handpieces. I set my BNRs to the exact speeds that I want them to achieve the results that I need. So if you use the correct burr with the correct handpiece at the correct speed, you can very efficiently prepare a tooth for whatever that might be. Whether it's zirconia.
How long have you been using electric handpieces, and do you use air driven anymore, or are you 100% electric?
Been electric for a very long time, well over a decade. With that, I did used to use occasionally some air-driven handpieces just to adjust, occlusal adjustments, that kind of thing, short things, just because at the time we didn't have lots of electric handpieces, so to not have them run through the sterilizer, we used them for that. The only time I picked up air recently was because my electric went down, and, it took about a week for them to get me what I needed to get it fixed, and once I did, it was, I'm back to full electric. I use currently I'm using the iOptima internal. So it just fits right into my, bracket table. And I set that to the speeds that I need for the burrs that I'm using. Or as I like to call it, especially when we're polishing something with like Shofu's brownies, greenies, I call them, if you over rev them, they're rubber bullets. And if you've ever been hit with one, you've been hit because you're not using the right speed. So always look at the instruction sheets and know what you're doing before you do it.
So before we get into the details of adjusting zirconia, your tools and methods that you prefer, I assume you're doing intraoral scanning in the office. You're no longer using traditional impression materials. And the other question I have is, are you designing your preps yourself in the office, or are you sending that out to the lab and delegating that out?
What I do is I'm probably for both fixed and removable and implants. I'm, again, 99.9%. I'm not picking up impression material. That's the last thing I want to do. I want to scan everything. I want a digital copy of it all. So we'll scan the preparation. I personally mark the margins. I think every dentist should mark the margins because they are the best ones to do it. All right. That doesn't mean the lab may not tweak something, but I thoroughly, and I tell all the dentists who work with me, you need to mark your margins. And in fact, recently, my new associate who just started said, boy, my preps don't look so good when I look at them on a 30-inch monitor. So, I said, you'll get better. And she's just out of residency. I said, you'll get better because you're going to be looking at your stuff on that big monitor, not like we used to look at it in impression material. So I think it leads to being a better dentist because you do better preparations. And if you mark the margins, the lab likes it better. At that point, we don't mill in-house because I haven't seen the ROI really be there. I use laboratories that, for the most part, what I call their B2B laboratories. I mean, laboratories have laboratories for labs. So I use some of them because I can get the same results at a lower cost. So I'm in a PPO office, costs matter. We're not getting full fee for service. So with that, I let them design the crown, but I do mark the margins. So when I get it back, it's how much adjusting should I do? And if you really spend the time and make sure the bite relationship is good and you've got a good scan, there should be minimal adjusting.
Okay, so let's say there is some adjusting. Let's talk about the technique and the tools that you use in your office for zirconia.
Okay, so let's start with the thing that may be the first part of adjusting, which is, hey, it's got really tight contacts and it doesn't go down. All right, so it doesn't go to place, the margins don't meet. So then we're going to mark the inner proximals, and there's various products for that. Microcopy has a film. Some people use occluding paper, whatever. Some people mark it with a Sharpie, whatever they're going to do. You don't want to just adjust with anything. That's really the key here. You want to adjust with something that's going to adjust as smoothly as possible and do it as efficiently as possible, because that's going to make your next step, which is the polishing, even easier. So I usually reach for these Microcopy Z-class burrs that are made just for adjusting. They come in various sizes and shapes. Those burrs have, the diamond impregnated and it's just not random. They're made to give less gouging, smoother finishes, that kind of thing. So I take that, I put it in my electric handpiece, I run it at 100,000 RPMs, all right, because I can set that with my electric handpiece, and very feather touch with that underwater, I can adjust those exact, spots, and then we take it back to the mouth. Do I need a little more? Do I not? That's just normal adjusting as we go back in what I call the fine tuning of, the insertion process. And that's kind of what we do. Now, once it's fully down and the margins are sealed, when you check the occlusion, now you're back to the normal stuff.
So you mentioned, Dr. Jablow, 100,000 RPM. Is there a gear reduction number on that, like 5-to-1 or something like that?
I'm using that because most people understand their air hand pieces. So what you're doing is with my BNRs, or any electric for that matter, you use a 5-to-1 handpiece. So if you're running at 40,000 RPMs, you're running at 200,000. All right. So because and the same thing happens when you use an implant drill, which is whether it's 15, 14, 16, 17 to 1 reduction, you're never going to get that kind of speed. It's the same process. So green ones are reduction hand pieces when you're in electric. Blue ones are 1-to-1. Most people consider those slow speeds. And then high speeds are, 5-to-1s, and you're just adjusting that. But you're looking at the absolute RPMs at that point.
And that's what you use for adjusting zirconia when you're doing that interproximal reduction to make sure that crown is seating properly.
Correct. So I'm running it at 100,000 RPMs, which is, at that point, if it's 5-to-1, you do the math, 20,000 RPMs. Right. You're setting it at 20,000, but the thing's spinning at 100.
And the burr that you like is a diamond impregnated burr. And what's the shape? What shape burr do you use for that?
Oh, they make. Usually, I'm using a feather edge diamond on something like that because I really don't want to take big amounts. But again, you can use whatever you think is appropriate for that kind of for that situation. Which for me on the interproximals, that's what I want to use. I want a really fine diamond that I can just kind of brush it away.
I've talked to a lot of KOLs, and it seems to me the popular thing to do today is to use disposable burrs. The added cutting efficiency of having a new burr each time And the simple fact that you don't have to re-sterilize a burr, which takes up time from your staff, and that costs money, the ROI on having a single-use burr far outweighs reusing a burr. And that seems to be the trend these days.
It's really simple because all the microcopy burrs come in single-use, packages. They're disposable. So we go through that. And like you were saying, once you use it, it's duller. Once you run it through a sterilization process, it's duller. So, I want the most efficient cutting because, again, I want this to leave the least amount of marks possible in my zirconia because ultimately I've got to polish it out. And then when we polish it out, I reach for actually microcopy makes zirconia polishing burrs that are single use. So we go to those also. All single use, all efficient. We're not cleaning things. We're not sterilizing them. That goes in the garbage can. And I get the best results that way. What we would call, and we're going to get into this a little bit, what we do on the occlusal. But again, polishing it up, with those burrs.
So once you finish the interproximal adjustments, the contacts look good, you believe the crown is fully seated. I assume you're using loops, some sort of magnification to make sure that you're visually seeing the margins are closed.
I wear magnification. I'm using oroscoptics, the dragonflies. I'm using 3.5 and 6.5, I think it is, or 6. So I can actually see it. We also take a radiograph to make sure everything is fully seated. I run the floss through the contacts to make sure that's easy. We ask the patient, are they feeling pressure? And a little bit of pressure is okay. I mean, I call it the new pair of shoes. They've got to get used to it. And then, if that's all good, now we're going to check the occlusion. We use articulating paper, various different ones, whatever you're fine with, whatever you're used to using, that's fine. Again, with most of these scanned crowns, I mean, there's not a lot of adjusting. There's many cases we put the crown in and there's nothing to do except cement it. But occasionally you still have to adjust things. So, we'll run them through both, what I call more of a static, the up and down. I don't know if you could hear me clicking. And we ask them to go from side to side, run up those cusps, inclines. And we'll look at it. And if the patient indicates that it doesn't feel correct, we'll then reach for another burr. So in these cases, again, I'm reaching for a microcopy, Z-class adjusting burr. And I may be using a football or I may be using a chamfer that's, again, not big ones, but smaller ones, to just be able to take down either that occlusal area or that area on the incline where the patient feels it's just not quite right. And we'll go back and forth on doing that, till the patient says that feels fine. But with that, I always tell people when you're scanning, make sure you can flip the model around. So go look on the inside and make sure that the cusps are fully in the fossa. Make sure it really looks down, because one of my associates had one that said it fit perfectly, but it was too high. And when we looked at her scan, it looked like the cusps were good on the buccal, but if you looked on the lingual, they weren't seated. And when we retook the scan, you could actually see the difference. So I always say, along with marking your margins, make sure you look at that occlusion and don't just assume it's correct, especially if you're delegating the scanning to an assistant. Then I would say, it still behooves you to spend the 2 seconds to look at it, and it may save you a lot of time in the end.
So now we're at a state where you've totally seated the crown. You feel like, as far as the adjustment for the occlusion, you're good. What's the next step?
So next step is hand polishing. And there's a bunch of stuff there's a bunch of research out there that says hand polished zirconia is kinder to the opposing dentition than just the stains and what they do in many cases to save time. So, if you can ask your lab to hand polish your zirconia, you're going to get a much kinder zirconia, in the occlusal situation. So then we'll pick up, again, I use microcopies. They make these polishing burrs for zirconia. We run them obviously at the appropriate speeds. Again, perfect reason for changing to an electric, because you've got the right speed. You can just dial it right in. Once you've dialed it in, then you just go through the process of doing that so that you can get that polish really back on it, and you can see it when I'm looking through my loops, I can see that there's no more scratch marks. There's no more all of that adjusting. It's gone. You want to, again, try and do that, underwater, because you really don't want to heat up zirconia. Because if you overheat the zirconia, you can wind up in a situation where, if you're lucky, it fractures right then and there, and you can put the tent back on. Or if you're unlucky, the patient comes back in a short time period and the thing fractured. And now that's a combination of preparation, making sure you have, enough tooth reduction so that you're not getting too thin of zirconia, because too thin zirconia becomes very brittle and it cracks. So with that, all of those little pieces of the puzzle help you to ensure that when you do adjusting of a zirconia crown, you're going to get the best results with I'll call it the least amount of trauma to the zirconia itself. And that's a key piece of it, because, again, overheating zirconia will lead to future problems.
So you polish those with water using your electric handpiece. And typically how long would you say it takes you to get that polish that you're looking for, to get those scratches out after you do the occlusal adjustment?
Minute, maybe two. Okay. Again, this stuff should be quick, because if you're using the right materials, like I said, if I'm using my microcopy sequence through all of this, I'm not getting big scratches. I'm not getting gouges. And then the less of those you have, the easier it is to polish the whole thing.
Right.
So that's why using one single burr one time, you get that better efficiency and smoother cut than you will if you're trying to use a burr 3 and 4 and 5
right.
and 6, or most dentists do, until it stops cutting.
Yeah, and you're also very aware of costs, because you said you're in a PPO environment. So you're not one to, and I'd say, throw things away, but you are throwing things away. But it's cost effective to you to use disposable.
It's cost effective. Yeah, it's cost effective because when you think about it, most people devalue the cost of doing the sterilization and the cleanups and everything else, because somebody's got to do it. So if you're paying an assistant, and in my area now, most assistants are somewhere around $30 or more an hour, 28 to 35, that's a big deal. I mean, if they're spending 15 minutes, between throwing in, cleaning it off, throwing it in a sterile, in the solutions, then packaging it, then putting it through, then taking it out, putting it in a box, then it's got to go to the room. We're talking about, even if it takes 10 or 15 minutes, you've got to put those costs into what it takes. And, with the cost effectiveness of these burrs, it just doesn't make economic sense.
Yeah, it's a far cry from the past, because I've told this story before on a podcast, but a friend of mine who's a periodontist who just retired, he lives in Austin, Texas. He bought a practice 36 years ago as a young periodontist. The first day working in the periodontist office, the same staff member stayed on. So the owner left, he was gone. And my buddy's sitting there doing a prophy, and he takes the prophy cup off and throws it out. And the assistant says, "Why did you do that?" And the periodontist says, "Because I just used it on this patient. It's a prophy cup." She goes, "Oh, Dr. So-and-so, that lasted the whole day." And he said, "Well, how did she clean that? How did he clean that?" And she said, "He dropped it in the blue solution for whatever and washed it off and reused it."
Like the barber shop.
Yeah, it sounds just like the barbershop. Yeah. So, and I always watch them do that. They take the combs out, and I said, God knows who preceded me in this chair. I guess you just have to pray a little bit. But the days with the way, like a company like Microcopy, it's such an extreme difference in the spectrum of infection control and efficiency. And, even when I was an endodontist and I would make access preps with round burrs, diamond round burrs, we re-sterilized them back then because, they were expensive. $10, $11 for a burr, and to use it once, to access it. We're not doing precise dentistry. We're just burning through the enamel and dentin to get to the pulp. But, eventually you have to go to disposable. That's just the way to go. So once you do the polish, you're finished with the polish. What else do you have to do before cementation?
So depending on what you're using will dictate the next steps. So, you can use resin cement. You can use, I use Ceramere because I don't have to prep the interior of the crown, whether that's you clean it out with IvoClean or whether you use, something like that, a zirconia conditioner, or sandblast it, all those things. I'm just trying to simplify my situation. So again, if you've got good resistance and retention form, there is no need to bond it. You can cement it. And so most of what we do is cementing with Ceramir. I use Ceramir because it's got a high pH. It starts at above 8, not like most cements, which are acidic. So again, you should have less sensitivity. And I'm not big on anesthetizing patients to insert crowns unless absolutely necessary. And it's not something I do on a regular basis. Then we place it in, have the patient bite on a cotton roll, make sure it's fully seated. And then I'm big on using a timer. I don't like guessing on anything that I do, whether that's topical anesthetic, whether it's waiting for the anesthesia to work. I pretty much have it down and, know the material that you're using. What's the set time? All right. So for Ceramir, it's 2.5 to 3 minutes. I place gauze over the crown, trying to keep it as dry as possible. And then, once the buzzer goes off on the timer, we go in, remove the excess cement, floss it, do what we have to. That's when I'm using the Ceramir. If I'm using some kind of resin cement before the final set, I need to be in there with floss in the interproximal, making sure that's clean before it fully sets. Because if it fully sets, anybody who's been down that path knows it's not fun to dig all that cement out.
Now, in the event that you do have a case where you have very minimal retention based on the prep design itself, then you'll bond. Then you'll bond the zirconia.
Absolutely. Then you want to bond. Okay. Then you got to go through all the steps. If you've got, especially like I call them, those short second molars, where there's not a lot of interocclusal space, do yourself a favor. If you've got the ability to put grooves in, if you got, drill a little dimple in the occlusal surface, do anything you can to try and increase your surface area, and stop that crown from being dislodged. Again, that comes just down to preparation. But if you've got those really short preparations, you've got to take that into account in what you're going to do. The whole piece of it is treatment planning,
right.
And understanding what you have to do, what materials you have to work with, both in the crown and the cementation, so that when you do that, you're going to get the best results you can.
Yeah, and Dr. Jablow, you also have to pay attention to the patient's occlusion. So if they're a bruxer, or if you see that they're clenching their teeth, heavy on the molar, and you're doing a molar with minimal retention of the prep of it itself, then you're looking at a challenging situation, even though you're using zirconia. So you have to be, I guess that's all going to be in your treatment plan, I assume.
Yeah, that's the whole idea is here. Why are you selecting that material? So especially if you got a short prep in a bruxer, I'm looking at monolithic zirconia, or actually, if that's the case, if I'm really concerned, I'm looking at gold, some kind of gold, because I don't want it breaking. Because the thing that's going to cost you the most money is redoing it. That's a bigger problem than just, eating a little bit bigger lab bill or something at the time. It's not just about efficiency and everything else. It's really about the outcome. If you can get to that outcome efficiently, it's win-win for both the dentist and the patient.
Yeah, absolutely. Amen to that. Have a great night. Thank you very much, Dr. Jablow.
You're welcome, Phil. Hope to do it again soon.